All right. So, good evening, everyone, and welcome to Regenerate's second webinar called Menopause. What is it and what do we do about it? We're so glad that you're here. My name is Tammy Wong. As I said, I'm the community manager here at Regenerate, and my role is to support and engage our community of women that are navigating hormonal changes. And with that comes hair loss. So, we want to bring in trusted experts into conversations like this one. And I have personally lived with alopecia for almost 30 years. I wear wigs. And so I understand how deeply these body changes can affect not only our health, but our confidence and our overall well being. So at Regenerate, we believe women deserve clear evidence based information and honest conversations about what's happening in our bodies, especially during transitions like perimenopause and menopause. Too many women feel dismissed, confused, and left to figure it out on their own. So tonight is about changing that. So before we begin our presentation, I would love to introduce you to the founder of Regenerate, Chastity Sullivan. And she's going to share a few words about herself and the heart behind why this work matters so much to her. So I'm going to bring her on here real quick. Okay. One second while I get this button. Okay. There she is.
Hi, everyone. I just want to take a moment to thank you for being here tonight. It truly means so much to me to see women showing up for each other, especially conversations around hair loss and hormonal health. I'm Chastity, obviously the founder of Regenerate, and this brand was born out of my own experience with hormonal hair loss. I remember feeling frustrated and unsure of where to turn, and realizing how little we openly talk about what happens to our bodies during postpartum, perimenopause, and menopause. Regenerate was created to be part of the solution, clean, intentional support for the scalp and hair, but also to create a space for education and empowerment. Because this isn't just about hair, it's about understanding what's happening to our bodies. I'm so grateful to have Dr. Abigail DeVries here to guide us tonight, and I really hope you leave feeling informed, supported, and not alone. I'm going to turn it back to Tammy, and she will do the introductions.
Thank you, Chaz. I'm going to go
Thank
ahead and
you.
backstage. Enjoy listening. All right. So now it's my privilege to introduce our speaker for the evening. Dr. Abby DeVries is a board certified family physician with more than 20 years of experience and is a Menopause Society certified practitioner. She is the owner of Sabia Health, a direct primary care practice dedicated to women in midlife, and it's located in Durham, North Carolina. Dr. DeVries has held numerous leadership roles throughout her career. She is the former chief medical officer at Piedmont Health Services, a federally qualified community health center, and previously served as market medical director for City Block Health, which is a healthcare startup focused on improving care for patients with Medicaid. Most recently, she served as senior medical director at Medical Home Network, a value based care organization supporting federally qualified health centers across the country. Dr. DeVries brings deep clinical expertise, leadership experience, and a strong commitment to improving care for women in midlife. We are honored to have her with us tonight to guide us through this important conversation. Dr. DeVries, thank you for being here, and I will turn it over to you.
Thank you so much. Appreciate the invitation, and I'm always happy to have the opportunity to talk about menopause and the changes that happen in midlife. And really want to think about this as not necessarily a negative thing, but it's just a transition. And the more you know about it, the more you're equipped to handle it. I'm going to share the screen here and make sure I get to the right thing. And just let me know if there's any problems with seeing this. So let's see. Is that working? I think that looks like it's working okay. So I'm just going to skip ahead here. So we'll talk a little bit about kind of just definitions, just to kind of level set, and then the symptoms of menopause, the impact it has on individuals and our society as a whole, and then what options you have for treatment and why you might want to consider treatment. I'm talking about kind of all the range of symptoms of menopause, but this definitely is a phase where if women have not had symptoms of thinning hair, that often starts in menopause and perimenopause. And we don't have a lot of data about specific hormonal treatment for hair loss, but it is part of the kind of package of treatment of trying to mitigate the hair loss. Even if someone has started with hair loss or earlier in their life. The other thing I wanted to mention is that we still have very limited data about menopause and even less than about perimenopause. And so I'm giving you the best data that we have, but we still have lots of questions and some that we may not be able to answer with research, but hopefully we will in the future. Okay. So just some definitions here. So menopause, again, it was really just one day, and that's after you've had 12 months with no menstrual period. The time leading up to menopause is perimenopause, and that can be, 7 or more years before you hit that final day. And then when we talk about postmenopause, when people say they're in menopause, it's really postmenopause phase, but we usually just shorten it. So those are kind of the three phases, and there's kind of sub phases within that. That's just kind of the range. And perimenopause can start really as early as the late 30s, and you can still be having completely regular periods, but still start developing some of the symptoms of the periods could change. They could become more irregular, heavier. Oftentimes, women will have to go on birth control years after they've needed to think about it just to be able to manage their periods. You can start with hot flashes and night sweats. Sleep difficulty is one of the more common things early in menopause, and mood changes, irritability, weight gain can start to happen, and then, fatigue, decreased libido, all things that are very subtle sometimes and can be overlooked by patients and their providers. So there's like 39 different symptoms that are part of the perimenopause menopause picture. So you're not going crazy. And then in menopause, the periods will stop. Like I said, the hot flashes sometimes will worsen in that early menopause phase. But then some of the other symptoms can sometimes go away as you kind of adjust to this new normal of a lower estrogen level. But then one of the things that then really does start to pick up the longer you are without estrogen is the vaginal symptoms. So vaginal atrophy will happen to everybody at some point without estrogen present. And so we'll talk about ways to treat that, but it is not something that people need to live with for sure. Urinary incontinence, urinary urgency symptoms, having to wake up at night just to pee, also as part of that picture of genitourinary syndrome of menopause. And then a silent thing, but something that we definitely pay attention to is a decrease in bone mass. And so the peak bone mass happens in your late 20s, kind of stable through the 30s. But then once you hit perimenopause, starts to go down. And the phase right around the transition to menopause is the highest period of bone loss at a time when you really are not necessarily thinking about that. So it's kind of a silent symptom. So those are all the symptoms. What's the impact on, again, women and society? We, especially as we're living longer, might spend up to 40% of our life in menopause. And so it is definitely something to pay attention to. 20% of the workforce is in either perimenopause or menopause. And women who are dealing with significant symptoms are 8 times more likely to have difficulty with their job. And some will even leave or retire early because they're unable to manage their symptoms at work. And then in some people, unfortunately, they can have the vasomotor symptoms, the hot flashes, feeling sweaty, waking up with night sweats for up to 20 years. And that's again a huge portion of someone's life. Again, the genitourinary syndrome of menopause is not symptomatic in everybody, but everyone will eventually develop it. But half of women are really bothered by it. Major cause of sexual dysfunction, and which then is a stressor for relationships and personal stressor. And then just thinking about the genitourinary symptom of urinary tract infections, Medicare could save billions of dollars if we actually got everybody treated effectively for that. Again, this is a major impact. And, there's what we also don't want to necessarily think of it as a disease because it's normal aging, but there's ways that we can kind of mitigate some of the negative impacts. A couple other statistics here. Depression risk increases significantly in the perimenopause period, especially for women who had symptoms postpartum. There's similar hormonal swings happening. And so if you had a history of postpartum depression, be kind of aware of the potential to develop symptoms again in the perimenopause. Sleep disruption is huge. Half of women will experience subjective cognitive decline and worry that they're sliding into dementia. And then weight changes and other metabolic changes happen very dramatically in this age range as well. And then I mentioned the bleeding that, again, sometimes requires surgical treatment or at least medical treatment. A couple of other statistics here, and then I think I'll move on. So again, the bone mass. So over 50% of women over 50 have low bone mass, which we call osteopenia, and about 20% or 1 in 5 will have osteoporosis, which is a big risk factor for hip fracture. One of the common things that will land someone in a nursing home when they're older, and loss of independence. And this is a very under-recognized and underdiagnosed condition. So right now, the recommendation is to screen for osteoporosis at age 65, when already women often will have very advanced osteoporosis. So in my practice, I'll screen people right around 50 as they're transitioning, or earlier if they have other risk factors. And then it's another thing that they know they need to focus on. Cardiovascular disease, 1 in 3 women will die of heart disease, and it's kind of eclipsed by some of the breast cancer discussion, which we don't want to minimize, but also recognizing that cardiovascular disease has lots of ways that we can impact it and decrease our risk, if we're more aware of what those risk factors are and what we can do, to stay healthier. About 50% of women will develop dementia. It's, again, much more likely than breast cancer. Cholesterol levels go up, not significantly, but they do tend to start to increase, as well as blood pressure and insulin resistance, which is kind of the precursor to diabetes. So little doom and gloom, but want to talk a little bit about treatment. And again, this is something that's had some major evolution over the last couple of years. So in 2001, let me back up a second here. 2001, there was a headline released about a study called the WHI, and the headline was that hormones cause breast cancer. And that actually isn't what the data showed at that point. And we have evolved in our treatment and use slightly different medications now that are most certainly somewhat safer. So there's been a chorus of women physicians over the last couple of years saying, we've gotten this wrong. We really need to think about longevity, as well as treating women who are suffering. And so the message really is there is likely some form of hormone replacement therapy that is safe for all women. And there are a few exceptions, but there are many fewer exceptions than we've been kind of led to believe. Want to just mention contraception. So birth control is either an IUD, often is used to control bleeding, or there's a lot of new oral contraceptive medications on the market that are very effective for treating the heavy bleeding. And so sometimes, even if a woman has other symptoms of perimenopause, we'll actually treat with kind of medications maybe for contraception to manage the bleeding, and then transition them to the hormone replacement therapy. So again, sometimes that's the first thing we go to. But then once a woman is clearly in menopause, or if she's not struggling with bleeding issues, we like to transition to what we call hormone replacement therapy. And that really is kind of four kind of specific medications. So the first is systemic estrogen, and I'll go through these one at a time. The other is systemic progesterone, and then vaginal estrogen specifically, and then sometimes, and not even half the time, but sometimes there are reasons to think about testosterone. And so the reason we use hormone replacement therapy is kind of two things. One is, if you're suffering now, that there's nothing more effective for treating your symptoms than replacing the hormones that your body is losing. And then also, we have really great data that estrogen replacement reduces the risk of osteoporosis. And some data, and again, not enough, but kind of directionally, data pointing that heart disease and dementia risk is decreased if women start hormones in perimenopause or early menopause. So it's kind of a twofold reason for why you might consider using hormones. And I think of it like, if you had low thyroid, we would give you thyroid replacement. And so again, it's not necessarily a disease model, but it's kind of a supplementation model. Systemic estrogen is most often used through the skin. It's safer, although some women, for a variety of reasons, will still use oral estradiol. But we have estrogen receptors in all parts of our body. So we think of these hormones as sex hormones, and their responsibility for in the reproductive cycle and allowing us to reproduce. But we also have receptors in our brain, our heart, our skin, our bones. And that's why we have all these different symptoms when estrogen starts to decline, because there's receptors all over your body kind of crying out for estrogen. So the most effective, again, way to alleviate these symptoms is to replace a little bit of the estrogen that your body used to make. And again, we have the bone mass preservation, the heart and brain protection. And we usually use something like this picture here, which is a little tiny patch that you change either weekly or semi-weekly. And that's usually what insurance prefers to cover, but it can be a spray or a gel. And again, in sometimes cases it's oral. Bioidentical to what your ovaries either still make in some quantities or used to make. It's derived from plants and again, exactly what you used to make. So generally there's no need to use compounded medications because this is FDA regulated, you know exactly what you're getting, and it's already bioidentical. And then vaginal estradiol, because we have so many receptors in that area, we often will use cream in addition to the systemic estrogen. Also, there are some cases of women who cannot safely take the systemic estrogen. And in the vast majority of those women, the vaginal estradiol is safe because it's only right there local. It's not absorbed. So there's no increase in breast cancer risk, for example. So breast cancer survivors even generally can use the vaginal estradiol. Usually it's a cream, but there's also a couple of other formulations. Significantly reduces the risk of urinary tract infection as women age and really helps preserve sexual function and pleasure and is very much underutilized, like I said, in women who've reached menopause. And then there's progesterone. So if you give a woman who has a uterus just estrogen, it kind of promotes growth of the uterine lining and over time can lead to uterine cancer. But the progesterone kind of tamps down that overgrowth. And so if you have a uterus, you have to be on some form of progesterone, which could be an IUD local, but more often than not is a oral progesterone pill, again bioidentical. All it is progesterone mixed in peanut oil, so very safe unless you have a peanut allergy. It's often what we start first in perimenopause because that level often will drop off before estradiol levels drop. And one of the most common complaints that women have in perimenopause is the sleep disruption, rage, anxiety, and progesterone is very, very helpful for this. Some people call it the chill pill. It is helpful in its own right, but necessary in some form if you're on estrogen. Um, some women do not tolerate it, and there's a couple of other ways to provide it, but generally this is the best tolerated and very inexpensive. So we talked about kind of two forms of estrogen and then progesterone, and then I'll talk just a little bit about testosterone. So when you hit menopause, your ovaries essentially shut down. Progesterone and estradiol levels essentially go to zero. Testosterone's a little bit different. In both men and women, testosterone starts to decline in your early 30s. And some women will get to a very low level very quickly and be symptomatic. Others will, not necessarily notice any effects of low testosterone. There's no, as far as we know, no kind of longevity benefit to testosterone. It has an indication for low libido, but I've also seen anecdotally that people feel less fatigued, have less brain fog, and maybe able to build a little bit more muscle when they're in the gym. And so we use it. We do not try to get to super therapeutic levels. We just try to get a little bit further up in the normal range. It is possible to get too much testosterone and have really significant side effects, one of which is actually hair loss in a kind of male pattern, which is not reversible. You can also have hair growth on the chin, deepening of the voice. So one thing that women often turn to is pellets, where there's something implanted that will last for several months and often overshoots significantly so that you get testosterone levels in the male range. People feel great, but again, there's these secondary side effects and there's no way to to turn back the clock once the pellet is injected. So I never advocate for those. Generally, we use, again, this FDA approved formulation, but use it for in a much lower dose. And again, I use this probably only in about 10% of women. Um, and usually it's because of libido that hasn't improved with estrogen, or they're, still have normal estrogen levels, but are noticing lower libido. So just talking about a couple of other symptoms here. So weight gain is something that tends to happen right along with perimenopause and menopause. We don't unfortunately see that when women go on hormones that their weight gain reverses. So there's something else likely at play here. And people obviously are frustrated with the kind of change in body composition. So they may put on weight and also have more weight centrally, which is a health risk if it's visceral fat, which is kind of fat around the organs because it's metabolically active, can lead to insulin resistance and promote diabetes and inflammation. It gets harder to put on muscle mass as we age, partly because of that declining testosterone, but also because of more resistance in our muscles to kind of responding to the challenges that are placed on them. It's really important to make sure people are getting enough protein and fiber, and trying to make sure that they start a meal with greens and protein, and then if they're having carbs, to have those towards the end of the meal. And then the GLP-1s are a very, very, very effective treatment for weight gain. They're becoming more affordable. There are some insurance companies that are covering them. An oral treatment just came out that is cheaper. And then there are some older medications that have been around, and providers are getting more comfortable with them as people are coming to them with weight concerns, recognizing that there is something that can be done about it, but then unable to afford the GLP-1. So there really are options for women, and I've had a lot of women have really great success with a variety of different treatments, as well as lifestyle changes and kind of managing stress and sleep and those things. So it's not a kind of problem without a solution. One thing that I have seen, unfortunately, is some hair loss and hair shedding with the GLP-1s, and there's not a lot of information about how to treat that. It is probably transient, but that is something that can worsen with the GLP-1. So just a word of caution. It's probably more common if people are losing a lot of weight very quickly. And so we really want people only losing about a pound or two a week to kind of gradually have their body reset. And then I always like to talk about exercise and stress, the importance of that for a variety of reasons. First is bone health. So if you build muscle, you put stress on the bones, and that helps to keep your bone mass, in a healthy range. Women sometimes will go to the gym and then realize that they can't work out because they've got, a frozen shoulder is very common, hip pain, and sometimes that's the first sign that their estrogen levels are declining. And so starting estrogen often allows people to get back into a workout routine. If they're struggling with sleep, it's harder to stick with a diet plan and exercise plans. So again, the progesterone is very supportive there. And then making sure that people are actually eating enough. And so that's a common thing that sometimes women will starve themselves, do a lot of cardio, but then that kind of just raises your stress hormone levels and makes it sometimes harder to lose weight. So really giving yourself permission to eat and eating healthy foods that have protein and fiber is the way to go for that. So then I want to talk a little bit about the breast cancer concern. It's very clear that estrogen does not cause breast cancer. So that headline was wrong and did not actually even really state what was seen in the study. And this was, before we had it's kind of the birth of the internet, right? And we didn't have many avenues for getting the correct information out. And so that's the headline that came out. And that's kind of what people thought for the past, 25 years. And many clinicians overnight stopped prescribing hormones. And many of us didn't learn really how to appropriately prescribe. And that's something I've had to learn in the last couple of years myself. The study actually showed that women who were on estrogen, which was actually oral estrogen, which was from horse urine, and synthetic progesterone, had a slight increase in breast cancer risk, but no increased risk in death. And that women who were only on estrogen, so if they'd had their uterus taken out and were only on estrogen, they actually had a decreased risk of breast cancer. So that part didn't make it into the headline. We now use mostly, like I said, transdermal estrogen, and it's bioidentical. And even when we use oral, we're still using the bioidentical, not the kind of combo horse estrogen. And we use the bioidentical progesterone, which has not been shown to increase risk in the same way. We don't have enough data to say conclusively that it doesn't increase the risk, but there's no data showing that it does. So if you have an average risk of breast cancer, meaning personal history, if there's a family history and you've been tested for BRCA, for example, and you're negative, there's really not any significant increased risk beyond your 1 in 8 risk as a female of getting breast cancer. And then again, likely not any increased risk of death. So just wanted to make sure that is clear. And then it's the calculation. So if you weigh that against the symptoms you're struggling with, the impact on bone health, potential cardiovascular and dementia risk, and then kind of decide for yourself what risk you're comfortable with, what you want to prioritize. And that's the conversation that you have with your provider about how to decide what to do. Another thing that kind of came out of that study was that there was this window of hormones. The current official guidelines still state that you should start hormone replacement therapy, and we're really talking about the systemic estrogen here, within 10 years of menopause or before the age of 60. Newer thinking, still not sort of in the official guidelines, is that age is really just a number. So I'm sure you can all think of people who are 60 who, put them side by side, there looks like there's a 20-year age gap between them. So it's more now of a personalized approach. If someone has already had a stroke or a heart attack, I likely would not prescribe. But if they're still active and healthy and want to preserve their bone mass and don't have any signs of cardiovascular disease, I will have that conversation with women. And I have people coming to me, in their 60s who are starting hormones for the first time. The heart and brain benefit likely does diminish. And there's a couple of studies that point to maybe a slight increased risk of dementia starting hormones very late, but the bone health still has a benefit. And then the stroke risk that we worry about. One other point about that is in the study I was just referencing, they were using the oral estrogen. The topical estrogen does not have the same risk as oral. So we don't necessarily worry about stroke risk either in the way that we used to with the older medications. So think about breast cancer, not really as risky as we thought. Heart disease and brain health, kind of a null effect as you get older, and the persistent effect on bone as you get older. And then there is, again, like I mentioned, really no date where it's too late and no woman who is too risky to use vaginal estradiol cream. So even women in their 80s who are struggling with, urinary tract infections, incontinence, especially if they already have osteoporosis and you worry about them falling, rushing to the bathroom, really huge potential impact with the vaginal estradiol for anybody who's perimenopause and later. Do want to mention though that there are some options. So for women who either choose not to take hormones or for whom it's too risky, there are some non-hormonal options. None of them are as effective as estrogen, but there have been some studies showing that there is some benefit. Actually, cognitive behavioral therapy for hot flashes has pretty good data. And some of them have more side effects, but just to point out that there are some options. And there are also some what are called selective selective estrogen receptor modulators that will act in certain areas as estrogen and as estrogen blockers in other areas, specifically breast tissue. So there are some for women who are higher risk that will actually not increase their risk if they have a significant risk for breast cancer. So, and there are some options. I will say though that a lot of times people will use herbal medications because they think they're more natural or safer. Again, what this is something that your body used to make. And so there's not much, in my opinion, more natural than that. And it's also very highly regulated. So if you are in this phase of life and would like support from a medical provider, my first recommendation is to start with your primary care provider or OBGYN. Many providers have been practicing for a long time, never stopped prescribing. And many providers are kind of starting to respond to the kind of outcry from women and are learning kind of the new thinking and able to prescribe for you. If you strike out there, then I would recommend going to menopause.org, where you can find menopause certified practitioners in your area and get an appointment there. And then the other thing I'll mention is that there are a couple of telehealth companies where you're not going to get the same kind of personal touch. But if you know you want hormones and want someone who is kind of knowledgeable, something like MIDI Health can also be an option. And a lot of insurance companies are covering that. So there are many, many more options available for people than there used to be, which is exciting. And now we're struggling with actually a shortage of the transdermal estrogen patch because so many women are prescribed it. So that's something that should get fixed soon. This is where you can find me. I'm in Durham, as Tammy mentioned. I'm currently accepting new patients. And so if anyone in the North Carolina area is looking, but also if you want to follow me on Instagram as well. And I am happy to take any questions. So I will stop sharing.
Awesome. Thank you so much, Dr. DeVries. This
Sure.
was really helpful.
So
Yeah.
I'll take the first one, insulin resistance. So I'm glad you I could talk about this as a whole other lecture, but so insulin resistance is quite common. 1 in 3 Americans has prediabetes, which is kind of an elevated blood sugar that doesn't quite meet the criteria for diabetes. But prior to that, what happens is that our bodies are less responsive to insulin, and so we start pumping out more insulin. And then eventually we can't make enough insulin and our sugar rises, and that's how the diabetes starts. Insulin is an inflammatory molecule, and so it leads to some of these issues of higher blood pressure. It actually probably contributes to dementia, certainly contributes to weight gain. And so there's this kind of vicious cycle you can get into with weight gain and insulin resistance. And so I screen everybody with a fasting insulin level, compare it to the glucose, and see if they are making more insulin than should be expected for the level of glucose that they have, and talk to them about physical activity and nutrition. A couple of highlights there: resistance training so that you're building muscle, because muscle loves glucose and it will suck it out of your bloodstream more quickly than any other organ. And then getting up and moving after you eat, even if it's for 5 or 10 minutes, or even doing some calf raises at your desk, will help get that glucose out of your system. And then making sure that you're eating enough fiber and protein, and starting your meal with some fiber or protein before you have the simple carbs will help keep that spike from happening. So again, a whole other lecture, but really, I think, important concept for everybody. But then, because unfortunately we become more insulin resistant naturally during perimenopause, it becomes more of an issue. Do these things go back down after menopause? So yes and no. So like most times hot flashes will disappear, the brain fog will resolve, but the bone, the bone continues, the genitourinary symptoms continue and worsen over time. And the mood generally tends to stabilize. So perimenopause is this time where you're kind of up and down, and that fluctuation is what causes some of the symptoms. But then some of the symptoms of kind of low estrogen will persist. So it's a little bit of both. And then around estradiol tablet versus the cream, they both are good. The cream is generally the one that's covered under insurance, very inexpensive. Women develop symptoms in different places. So sometimes women will develop some higher vaginal symptoms where they're having really difficulty with penetrative sex, things like that. And the tablet is good for getting way up there, but it doesn't necessarily treat the external structures as well. So I generally start with the cream. If people don't like the mess or for some reason don't tolerate it, then I'll try the tablet. But sometimes people have to use both too, depending on what their symptoms are. And then starting vaginal estrogen at what age depends a little bit on when you start to develop symptoms. So, 52 is the average age for menopause. You might start having some symptoms 10 years prior to that. But then there are some women who are still having regular menses at 57 and not showing any signs. So it really is about when you start to develop symptoms. And another thing I'll point out, because I don't know the age group on here, something that's also very underutilized: if you're breastfeeding postpartum, you are actually in a low estrogen state, and a lot of women develop symptoms then, and completely under recognized, and you could be using vaginal estrogen then. So for you, other colleagues, to think about using that then too. But there's no harm in starting it. You can't really start it too early, and then, like I said, there's never a too late either. Intermittent fasting is interesting. I have seen both arguments. So there's the camp of people who say that intermittent fasting causes more stress on your body, and that it raises your cortisol levels and you shouldn't do it. And then there are people who say that your body needs a rest, and you will decrease your insulin resistance if you fast, and that will help you to lose weight. The other kind of concept is kind of like eating with your circadian rhythm. So I think where I am right now on this is, if you're going to fast, you should do it at the end of the day when you already are somewhat more insulin resistant, when you can kind of sleep through the part that you might be the hungriest, and feel your day in the morning with a lot of protein and fiber. And I don't know that I'm a proponent of the prolonged fast, although I know some people are. So again, not enough information, and it also is kind of try it and see if it works for you. And if it doesn't, then maybe try something different. I think I got to the end of the questions. Happy to entertain any others, or if I missed any, please point that out too.
Yeah, I think there was one about, I don't think you answered it anyway. It was one that came from the registration page. They said, although I'm using HRT and testosterone cream for the past 2 months, my libido is still on the lower end. Why is that?
Okay. So a couple of things on that, and then I do see about a couple other questions, so I'll go back to those. So the one thing I would make sure is that, I mean, have you optimized your estradiol level, or so do you need a higher dose of the estrogen patch? So there's like 5 different doses, and a lot of times people will get stuck on the lowest one, and no one ever increases it. So that's one thing to consider. And then I would get your testosterone level checked and see if you've actually had a bump, and make sure that you're absorbing it. So the typical dose is, 1/10 of the male dose, but sometimes women will need to use more. I would be cautious about that though, because I think there's big drawbacks to using too much. And then thinking about, are there other factors? A great book that I recommend to almost all my patients is called Come As You Are by Emily Nagoski. And she goes, it's not about perimenopause specifically, but it's just about female libido and kind of the differences between responsive and the opposite of responsive libido, and things you can do that are kind of not related to the hormones. So that's a very good book. And then the other thing is making sure that if you're using vaginal estradiol effectively too, because the vaginal estradiol will increase the vascularity and the nerve sensitivity there. So that could help as well. So, and I'm happy to answer anything else about that. And then, okay, so it sounds like you did that, yeah. So, and then I think I'm just thinking about, are there other factors, like, are you getting enough sleep? Is your stress managed? How is your relationship? And then there are 2 medications, one called Addyi, that are specifically for hyposexual desire disorder. Mixed data, and of course they're very expensive, but that would be another thing to consider with your provider around that. Panic attacks and anxiety, absolutely common in perimenopause. You're on this roller coaster, and the first thing I would try would be a little bit of progesterone. So I think it's something like 30% of women in perimenopause are on some sort of psychiatric medication, many of them not on hormones. And so if we give people back a little bit of what they're missing, often that can correct. And then, I had a conversation yesterday with a Reiki provider. Menopause is also a time of transformation in our brains in the same way that puberty is. And, we go through this pruning process in puberty, and something similar is happening in perimenopause, where we're like tired of carrying stuff, is what the way she said it, which I thought was a great, great thing. So, therapy, trauma support, things like that can be very supportive as well. The GLP-1 question, and being on GLP-1s forever. That is what the official line is that that's a maintenance medication, that obesity is a chronic condition that we need to treat. It depends a little bit on how much you had to lose and how much you really get locked in on lifestyle. And are you building muscle while you're losing weight, such that your metabolic profile is really shifting? So it's not definite, but there are a lot of people who find that they can't keep the weight off if they don't continue the GLP-1, which we don't also know of any, I mean, other than your pocketbook pain, which is real, significant long-term effects. In fact, probably, we're finding out all these different things that it's helpful with. So I wouldn't be scared to try them for that reason. But then there are also some older medications, one's called phentermine, which was part of the old fen-phen, which I've seen really great results with. You can use that with something called Topamax, which is a seizure medicine. And some of those are a little gentler, and so I think it's easier for people to come off of them. They're also much less expensive. So I think because of this raised awareness that, oh, there's something we can do about obesity, that people are going to their providers and having conversations about things that they can use medically. And so some of these older drugs are becoming more popular as well. The HRT and the hair loss with testosterone, yeah. So I wonder if you had pellets. If you overshoot on testosterone, it can be really disastrous. So again, I don't use pellets. And I'm actually using less testosterone than I was a while ago, because I think there's a lot we don't know about it, and so I'll use it, but it's definitely not my first line. And then testosterone, there's a range. It depends on whether you're doing free or total testosterone, but there's a women's range, and you really don't want to go above that. And that's when you start seeing the side effects. So generally, in women who are not getting doses above, to get them above the normal female dose, they will not see the side effects. And usually it's because they've overshot and so there, you can also do pellets for estrogen, but again, it's really expensive, and your insurance doesn't cover it. So I really, really have people start with the FDA approved Very occasionally, I'll do a compounded formulation for whatever reason, but you really for your pocketbook again, start with what is covered and is really going to be the safest. I guess one thing I'll just say is, so again, midlife is a transition. It's a time to kind of think about what you want to keep and what you want to jettison. So it's not all negative. And also a time where you're setting yourself up for future success. So in your 60s and 70s. So really making sure you know what your bone health is, what your metabolic health is, specifically around insulin and prediabetes, and then that you're managing your cardiovascular risk factors. So is your blood pressure normal? Is your cholesterol level in a good range? Again, the prediabetes, stop smoking if you are a smoker. Um, and don't be afraid to take advice on starting, for example, a cholesterol lowering medication, because we know that those also work. And so I think, this is the age where we start to have like pill boxes full of medications. And, but there's a lot of good data for some of these things. And I wouldn't be afraid because, not intervening can lead to more problems down the road, more medications. So just kind of that whole picture. Now's the time to kind of get in the habit of kind of knowing where you stand on those different things.
Yeah. Amazing. Well, I'm going to drop in the chat our Better Mode community link. That is where we have a private community so that if you guys want to continue these conversations, ask questions, you can always do that in a private space there. Also, if you're not following us on Instagram, would love to have you there. Just want to also say follow Dr. DeVries and Sabio Health on Instagram. She's given us so much great information and really appreciate you all joining us today. And we hope that you found it as informative and helpful as I did. I feel like I learned a lot. So yeah, just keep being engaged with us. And we look forward to doing more of these webinars in the future. Thank you so much, Dr. DeVries.
Yeah, it's a pleasure to be here. Thank you.
Bye all.
Bye bye.